for third year's pathology or second year's physiology and anatomy. Yeah, because it's mostly clinical lecture, but I hope that the information I say today will stay with you forever, basically, so you don't forget thyroid. Yeah, okay, so I hope everyone can see my screen. Moment. Give me 1 second. Okay, good. So now everyone should see my screen. Can you see my screen? You can use the microphone. Okay, good. Yeah, so I will post everything on my lecture after on my YouTube channel and my social media, so you can have a look whenever you reach that point in fifth year, sixth year, or in your clinical years to review everything said today. Yeah, so that's my website and that's my YouTube channel. And also, I think UIMS will post their own version on their own channel. So just try to focus now to understand rather than making notes, because it's better for now to just get it and then make all the notes later on. You can also text me for any questions you have and I will try to answer them. Okay, so studying thyroid, I hope you can see my mouse as well. You will start with anatomy, histology, including the embryology of it, and then in the next year, or depending which faculty you're in, the biochemistry and physiology of it, so you understand how it works. Then you will study pathology in third year, so all the diseases of the thyroid. And finally, you enter the clinical years and you will study internal medicine and other related specialties, for example, surgery, which is a treatment for some of the pathologies, as well as oncology and etc. etc. So you will come up against thyroid in many different specialties, not just internal medicine, not just endocrine. And especially important is pediatrics. It's a completely different, let's say, aspect of the thyroid because it's very important for the CNS development. That's a few words for pediatrics, so you will not be lost. The first 3 years of life, the CNS development is really dependent on the thyroid. So if you have some problem, it will cause psychomotor retardation. That's the CNS brain problems, as well as growth. So thyroid is important for growth. After the third years, the CNS is not so much affected by the thyroid. The growth is still affected, and then until puberty, it's responsible for the initiation of puberty. So that's pediatrics. And after puberty is the same as adults. So until the puberty, the thyroid has different functions. You will study it differently. And this is like a baby, for example, with the congenital hypothyroidism, how it will look like, including if you do all the reflexes and CNS development tests, you will see that it's retarded. It has psychomotor retardation. And finally, once you graduate, you will enter the hospital. You will start to do clinical practice. So you will do physical exams, ultrasounds. You will interpret the laboratory and also the treatment, like the dosages and stuff. Yeah, so the way you can go and study about it as a revision when you're in clinical years, revise your hyperthyroid and hypothyroid, how they manifest, so clinical symptoms as well as the labs, like how the labs will change. Then practice your physical exam, practice palpating the goiter, classification of goiter, and also try to find the signs and the symptoms on the patients. Then practice your ultrasound and watch scintigraphy. You will not do, but you can see it on the computer in the files. Try to see how the nodules look, how the inflammation looks like, how the thyroid looks like. And finally, revise your antibodies, which is important for autoimmune diseases, inflammations, cancers, and also it's also a screening. When you have family history, you could do it as a screening to catch it early. So I had a discussion about the thyroid with my endocrinology doctor, let's say, and he told me that he's doing his specialty on thyroid. And I was making fun of him because what can you say about thyroid? It's just hyperthyroid, hypothyroid, that's it. How can you be specialist on thyroid? Yeah, and then I started studying thyroid and I saw how complicated it can become. So the more you know that you don't know. And now I am at the point to say that about the thyroid, I have no idea what I'm talking about because the more you study thyroid, the more you understand it's complicated. It's not so simple. And what I did to my professor, I see students doing it to me now. They tell me, oh, you're going to make a lecture for thyroid. It's just hyperthyroid, hypothyroid. But we're going to see today that it's a bit more complicated than that. Okay, so the function. Let's start with the functional pathology. So we said the function is hyperthyroid, hypothyroid. So hyperthyroid is when you have excess of thyroid hormone function in the organism, also called thyrotoxicosis. Do you know any causes of hyperthyroid? You can answer or you can write in the chat. Can you unmute your microphone? Try to say something. Maybe guess. I know you're second years, but
Inflammation?
inflammation. Okay.
Okay, or like a growth?
Okay. Yeah. Good. So when we have causes, it's easier if we start to classify it. So we remember the causes, or we can target the causes better. I know you're in second year, so in third year, classification is a must. And the classification of hyperthyroid is and hypothyroid, they go with pathophysiology. So depending on the mechanism that the hyperthyroidism or hypothyroidism came to be, we can classify them as too much TSH receptor activation. So that's the first step. You know that we have TSH going to the thyroid, and then you have some diseases that will cause the receptor to be activated, and of course this will cause more hormones. The most common cause of hyperthyroid is Graves' disease, and we will talk about it in detail later on. Also, it can be some pituitary adenoma that is secreting TSH, or remember that the human chorionic gonadotropin is also similar to TSH and similar to LH, so they can bind to these receptors. So HCG can bind to the TSH receptor or the LH receptor and cause a hyperactivation. Then we have the thyroid itself, which is unregulated. It doesn't listen to TSH. It's independent of TSH, and it's just producing hormones. This is called toxic. So we have toxic adenoma and toxic multinodular goiter. So these two is examples where the thyroid is just secreting toxic amounts of hormones without listening to TSH to stop or to slow down. Then we have preformed thyroid hormones. You know that how the thyroid looks like. It's basically like a swimming pool. There is a colloid, let's say, swimming pools, and around them is the follicular cells, and they are creating the hormone, and the hormone is stored inside these follicles. So the hormone is there, it's bound, and it's not available for use. So when you destroy these follicles, and it's imagine like you have a swimming pool that you destroy the walls and the water is going everywhere. So yeah, this is called follicular destruction. So you will destroy the follicle, and the thyroid hormone is going to escape into the blood, and you will have more in the blood. So for example, we have Hashimoto. We're going to talk about it later on, and also subacute thyroiditis. We're going to talk about the subacute thyroiditis differentials later on. And then in the end, we have excess thyroid hormone in the serum. This can be iatrogenic, you are overdosing on drugs, or some teratoma, or the patient is taking it by himself to lose weight. But now there is a better drug that people are using it. It's more trending on TikTok and stuff, and it's Ozempic. Semaglutide. It's a diabetic anti-diabetic drug, but people use it for weight loss. And FDA, the American Responsible Association for Drugs, approved it as well for obesity. So yeah, it's indicated as well. So people will start using Ozempic more than thyroid, but yeah, still some old people can use thyroid to lose weight. Do you know some symptoms of hyperthyroid?
Weight loss.
Weight loss, anything else?
Rejection. Palpitations.
Okay. Anything else?
Tachycardia.
Okay, I will not stress. I will not pressure you.
Is it like inability to sleep as well or something?
For
Like difficulty in sleeping?
hyperthyroidism, irritation, agitation, yes. So sympathetic system. Uh, I was waiting for you, someone to say, do you know what is myxedema? Have you ever heard this term before, myxedema? And do you know if it happens?
No, sorry, no.
Okay. Okay. So basically, okay, nothing in the chat. So basically, fibroblasts, they have a TSH receptor as well. And this can be stimulated, of course, by TSH. So TSH will activate it. So too much prolonged TSH overactivity, let's say, will activate them, as well as antibodies to the TSH receptor, which are stimulating. So TSH receptor antibodies, we have stimulating and blocking. So if you have prolonged TSH or TSH activating antibodies, then the fibroblasts will activate, they will secrete glucosaminoglycans, and these will trap water inside them, and it will make something like an edema, but it's not actually edema, it's not water, it's water with the glucosaminoglycans, and we call it mixed edema, and this is a non-pitting edema. It's like a jelly, you cannot make a pitting on it, while water can make a pit, because when you press on it, the water goes away, but this one doesn't go away. It's like a sponge. Yeah, so we have the Graves' disease, which they stimulate, antibodies stimulating the receptor. Or if you have long-standing hypothyroid, then the TSH is from the pituitary higher and prolonged. So the fibroblasts are again stimulated. So this is a hyperthyroid case and this is a hypothyroid case. So you can have mixed edema in both hyperthyroid and hypothyroid. But other hyperthyroidism, non-Graves, the TSH pituitary is suppressed, so you don't get the mixed edema. So the only way you get mixed edema in hyperthyroidism is by a stimulating antibody, so in Graves' disease. What about the eyes? Does the hyperthyroidism affect the eyes? Is it only if in case of Graves' disease, as we've seen here, that the Graves' disease is going to make problem in the eyes? Do you know what's the difference in the eye symptoms between Graves' hyperthyroidism versus other causes of hyperthyroidism in the eyes, the eye thyroid disease, or you've never heard of it before? Mixed edema. Wait. Okay. Yes. Okay. So yeah. Yeah. You're right. So in thyrotoxicosis, that's hyperthyroidism, we have sympathetic oversensitivity. This is why one of the treatments in the acute settings is to use beta blockers to remove this adrenergic sympathetic activity. And how it manifests is that the people stare at you, like you think they stare at you, and they have a lid lag. So how do you do the lid lag? You tell the patient, follow my finger. So you make your finger on the top of the head, and then from up you put it down very fast. So you bring it down your finger to your level, and normally the eyelid, the top, should come down. You see the top, the eyelid should follow normally with the eye. What we call a lid lag is when the top part here and here is the same. It didn't come down to the level. So the eye comes first, but the eyelid, because it's a muscle, it's slow to come down. This is called lid lag. So that's in hyperthyroidism, how it manifests. It's due to sympathetic oversensitivity. In Graves' orbitopathy, we said that the antibody is activating the fibroblast. Then what happens with the eye? Behind it, it's built up the kind of like mixed edema, so it's pushing everything forward. You have exophthalmos, another word for it is proptosis, and this can make ulcerations on the eye. So it doesn't get wet enough. Yeah, ulceration is a complication, so it's getting dry. Also, you have all this inflammation of the muscles here, so there is pain. Dearrangement of the eyes, so you have diplopia as well, and then around the eye, periorbitally, you have edema, the mixed edema. So that's the difference between thyrotoxicosis, like a normal hyperthyroidism case, which is sympathetic oversensitivity, versus Graves' orbitopathy, which is actually stimulating the fibroblast. So when you talk about the eyes in hyperthyroidism, know that Graves is by itself. That's why it's called Graves' orbitopathy. Yeah, so it's an entity by itself. Everything else has to do with sympathetic oversensitivity. Do you know what happens to the glycemia and what happens to the lipidemia during the hyperthyroidism? What happens to the metabolism? Go up or go down? Glycemia, lipidemia?
go up, maybe?
Which one, glycemia or lipidemia?
Glycemia?
Okay, why would glycemia go up?
No, sorry, I would say lipidemia. If it increases, like glucose breakdown, so maybe
Okay.
lipidemia should increase.
Okay, so basically hyperglycemia, it becomes like a diabetes type 2. It's peripheral insulin resistance, so the glucose is not getting broken down. What gets broken down is the fat, right? So that's why you lose weight. You have hyperglycemia in your blood and the total lipids are low. We don't know the exact mechanism. Maybe it's due to cholesterol converting to bile acids. We don't know the mechanism. We just know that there is hyperglycemia and low total lipids in hyperthyroidism. Okay, so the lipids are getting used, you lose weight because the lipids are getting used, and hyperglycemia in your blood. There is a mnemonic for the symptoms of hyperthyroidism. So thyroidism, you know the word thyroidism. Y and R, there is other words for it, but I don't like them, so I just combine them into metabolism. So two letters, two for metabolism: hyperglycemia, hypolipidemia. The first one is tremor. So how can you see the tremor in the hands? You just put the paper on top, and you can see the edge of the paper moving better than the fingers. So this thin of paper, it makes a tremor more noticeable. So a tremor, the heart rate is going up, and this is a bit dangerous because it can activate arrhythmias or atrial fibrillation. The systolic blood pressure goes up. Then you have some menstruation problems in women. This is because when you have hyperthyroidism, TSH is lower, and it's also affecting the reproductive organs. So oligomenorrhea, ophthalmopathy, we said this is not the Graves' orbitopathy, it's just the lead lag with the sympathetic symptoms. Intolerance to heat, there is a warm skin and thin hair, and they cannot tolerate the heat. They are already warm, so they don't lose the heat so much. There is sweating, shortness of breath on exertion, irritability, sympathetic system activation, hyperreflexia, and finally muscle wasting and weight loss. So that's, I think, the most important symptoms. There is also others like the bone changes or some goiter in some cases, and also anemia is of the dilution type. So you have more water coming in and diluting the anemia is normocytic, normochromic, but dilution anemia. So the most important is this thyroidism. If you can put as much symptoms on this thyroidism mnemonic, you're set to go for your exams and for your clinical career as well. Diagnosis, we can use some antithyroid antibodies. Do you know any antithyroid antibodies? We just said some right now. In Graves' disease. Okay, so there is no one in the chat either. Okay, so basically there is 3 antibodies, antithyroid ones. The one is the peroxidase, so TPO. The other one is thyroglobulin, so TG. And the other one is TSH receptor, so TRAB or TRAG. It depends which literature you're using. So how do you make a diagnosis of hyperthyroidism? First, you take the history. You see if there is some family history or personal history or overdosing. Then you do a physical exam. You see the signs and symptoms. Do the ECG for the heart because we have tachycardia. Try to find maybe some arrhythmias. TFTs means thyroid function tests. They consist of TSH and free T4. Maybe you can check T3, but T3 thyrotoxicosis is a bit rarer. And the TSH, the axis of TSH in physiology is mainly driven by the free T4. So that's why we do TSH and free T4, and we can estimate the axis and what is going on. For the antibodies, we said anti-TPO. That's usually a sign for Hashimoto. There is anti-TSH receptor. There is activating for the Graves. We talk about it on the fibroblasts. And there's also a blocking type for Hashimoto. But you can see here the blocking type is in Hashimoto is only 10% of the patients have such an antibody. So we don't use that one for Hashimoto. We use anti-TPO for Hashimoto. And anti-TG, the thyroglobulin, also for Hashimoto. And then for imaging, we can do an ultrasound. That's easy to do. Everyone should be able to do it. And then for some cases, we use radioactive iodine uptake. It's a scintigraphy, so it's like here. and you have hot and cold nodules. Hot nodule mean that it uptakes the iodine more than the rest of the thyroid, and then cold nodule mean that it doesn't take it at all. It doesn't uptake the radioactive iodine. So do you know which iodine isotope is used for scintigraphy and which one for ablation? Do you know the isotopes of iodine? How many types of iodine isotopes are used in medicine? Anyone in the chat? No one in the chat.
I don't know what's what, but I know there's something about iodine 127.
Okay.
I think that's an isotope that's used clinically.
For scintigraphy, we'll use 123 or 131, depends what is your. You can use both, but usually it's 123 because it's not damaging. And for ablation, you use 131. That's the isotope that is going to kill everything. So for example, now if I have a patient who did thyroid surgery, they removed the thyroid because of cancer, and I want to scan the whole body to see if there is any metastasis, I'm going to use the 131 because I want to find the metastasis, but at the same time kill the metastasis. So I will do a scintigraphy with 131, and everything that is found, it's possibly a metastasis, so I'm killing it. But if I just want to make like a diagnosis without killing anything, I will use 123. Yeah, so that's the isotopes. Do you know any hyperthyroid treatments? Do you know what are thionamides in pharmacology? I know it's a clinical lecture, but if you try to guess, how do you treat hyperthyroid, or what are thionamides? I'm looking in the chat. No one. Okay, so basically, thionamides, they take week to have an effect. That's one of the good and bad things of endocrinology, that you have time to fix things. Methimazole is a thionamide that is the active form. Carbimazole is a prodrug. Prodrug means that you take carbimazole and then it will be converted in your body into methimazole. So these two are the same drug, let's say, just different forms. PTU, propylthiouracil, it's also a thionamide, but it's hepatotoxic, so we don't use it. We only use it in first trimester of pregnancy because it's less teratogenic. And then in the second and third trimester, we switch back to methimazole or carbimazole again. So PTU is only used for first trimester pregnancy only. That's your gynecology exam and your internal medicine exam, maybe. Yeah. So first, how you treat hyperthyroidism? Treat the symptoms. So the beta blockers, if not contraindicated, can be used. They will help with the palpitations, tachycardia, tremor, anxiety, and heat intolerance. So they're very, very good. It's like taking an antipyretic, let's say, like paracetamol. So yeah, beta blockers, it's a symptomatic treatment. Then we start with the antithyroid treatment. That's the thionamides, but it takes weeks to have an effect. So we started, and the beta blockers will help with the symptoms until the thionamides kick in. So methimazole and carbimazole. In an emergency or in special occasions only, you can add something called potassium iodides. These ones, they don't stop the synthesis, they stop the release from the swimming pool, from this colloid. So the methimazole and carbimazole, they will stop the synthesis. That's why they take weeks, because we already have preformed thyroid storage in our thyroid, preformed thyroid hormone, as we said. And then potassium iodides will stop the release of this preformed thyroid hormone. So that's why it's faster onset. Take 1 week, not many weeks. So it's on special occasions only. And if we don't have an effect with these thionamides, then we can do some surgery or radioactive ablation. We said with the 131 iodine. Don't use the radioactive ablation in pregnant women or children. We prefer surgery in these two patients. And then, since the thyroid is still not there, we can use lifelong levothyroxine. That's a treatment for hypothyroidism. This is basically artificial T4. So yes, we're destroying the thyroid, and then we take over the function of the thyroid artificially, iatrogenically. Or what they can do is go back to carbimazole and have carbimazole for life. So yes, that's the most definite treatment, let's say. But initially, we do some symptomatic treatment and we give some synthesis blockage, the thionamides. Do you know any life-threatening emergencies that have to do with hyperthyroidism? like a specific condition of hyperthyroidism that is considered life-threatening emergency? Have you heard about it? Okay. So I'm guessing everyone is second year? Like everyone is second year? Okay, so I will assume everyone is second year and I will skip all the questions. I will just ask the questions and then just answer them myself. So that's the thyroid storm, basically. What is thyroid storm? It's caused by either a lot of thyroid hormone suddenly in the blood, for example, overdosing or stopping the carbimazole abruptly. That's why we don't want to have the patient on carbimazole, because maybe something in the future happens and they stopped it, so they will go into the thyroid storm. That's why we prefer to do one of the definitive treatments here, like surgery or radioactive ablation, rather than having the lifelong carbimazole. Yeah, or maybe the sensitivity to the thyroid hormones is increased. For example, some infection happens. So that's another reason why we don't want to have lifelong carbimazole, because once they get an infection, we need to change the dosage and stuff like that. So if it doesn't work, we will suggest radioactive ablation. The result is a life-threatening hypermetabolic state. It's called the thyrotoxic crisis, and that's the thyroid storm. So the main symptoms, it's what we just said, exacerbations of the hyperthyroid symptoms, but also the CNS. That's why it's life-threatening. The heat intolerance becomes fever, so they're super feverish. You can see here the higher the fever, the more the score they get. Tachycardia, the arrhythmias. At first they have high blood pressure because of the tachycardia, and then this may cause MI. But then we also have GIT symptoms like vomiting, diarrhea, and this will cause dehydration, so the blood pressure goes lower. And then this low blood pressure shock, it's called high output congestive heart failure. They have a heart failure. That's, I think, the most important mortality thing. That's how they die. But what is important for us to have a suspicion for thyroid storm, like for diagnosis perspective, is the CNS. If you see anything, hyperthyroidism with CNS, like from agitation until seizure or coma, you can see here the CNS manifestations: agitation, delirium, seizure, coma. With laboratory suggesting hyperthyroidism, that means high thyroid and low TSH, the feedback loop, then you should start the treatment. This is the seven criteria scale by Burg and Wartowski. You can see here temperature, tachycardia, fibrillation, congestive heart failure, GIT problems, CNS problems, and if you know what caused it, if you have a history, this cause, then you have impending storm or thyroid storm. So that's a scale how to calculate if the patient is having a thyroid storm. Do you know any treatment for thyroid storm? Okay, so I'll just answer this as well. It's a life-threatening, so we need to go to the ICU. Here we can give some medications which are hospital only, or we can give IV medications. We can also monitor them. We can give higher dosages, so that's why we have to take them to ICU. The treatment is more efficient. Then we have symptomatic treatment. So again, if not contraindicated, give the beta blockers. Hyperthyroidism, beta blockers. That's the way to go. It will help with the symptoms, the arrhythmias, but you cannot give it in acute decompensated heart failure. So basically, if you are too late, you cannot give the beta blockers. That's why it's very important to do an early diagnosis and give the beta blockers before it goes into the heart failure. Then for the fever, antipyretics, external cooling. For the GIT and hypotension, dehydration, you can give the fluids, correct the electrolytes. And then for the CNS symptoms, you can give benzodiazepines. This is to relax the brain, to stop the brain. Treat the cause or what was the provocation, and then move on to removing the effect of the thyroid hormones from the body. So we have different ways to do it. Why did I put here the quotation marks like synthesis blockage? Is because we don't care so much for the synthesis blockage at the moment, because we said that synthesis is going to take many weeks to have an effect. So we will not use the thionamides this time. We're going to use the PTU. Why? Because the PTU also blocks the peripheral T4 to T3 conversion. So the synthesis is not important at the moment. What is important is the peripheral thyroid conversion. So that's why we use PTU and we don't use methimazole at this rate. But before you discharge them from the ICU, then you need to remove the PTU because we know it's hepatotoxic and give the thionamide, so methimazole and carbimazole. But at this phase of thyroid storm, start with the PTU. So that's another indication of PTU. We said first trimester pregnancy and also thyroid storm. Continuing on with the peripheral conversion blockage, we said already the high dose PTU. We can use the beta blocker. It also has the effect of peripheral conversion blockage. So we're doing two things with one drug. So we gave the beta blocker as symptomatic. We gave the PTU as, let's say, synthesis blockage, but both of these drugs, they stop the peripheral conversion blockage. Then we have preformed thyroid hormone. Have you ever heard of the Wolff-Chaikoff effect? It's going to help block the release of the preformed thyroid. So basically, if you put iodine in the body is telling that, oh my God, there is too much iodine, I'm not going to release the thyroid hormone. It's onset within hours and it lasts for 5 to 10 days. So that's why we can take advantage of this by using potassium iodide. Yeah, it's jet irritant, so be careful when you give it. And if you know that it's toxic goiter, don't give it with the thionamides. Give it 1 hour after the thionamides. Yeah, and then we have the wonder drug here that has many effects is glucocorticoids, for example, hydrocortisone. This is going to stop the peripheral thyroid conversion. It's also going to stop the autoimmune attack on the thyroid if it's Graves' disease. And it's also going to help with any adrenal exhaustion or insufficiency, because we know that without cortisol we die. It's like very important for life. And if this patient has been in stress for so long, the adrenals, they run out of their hormones. So it's called adrenal insufficiency. So that's why it's good to give also the hydrocortisone. And the last resort treatments, like this is, if it's too severe, it's plasmapheresis, which is going to remove the thyroid hormone from the blood directly, or similarly cholestyramine that can bind the thyroid hormone in GIT and then excrete it from the body. So you know that there is a recycling in the GIT of the thyroid hormone, and by using cholestyramine, it's not going to recycle it anymore. So you're going to start to lose this thyroid hormone. Or you can do some urgent thyroidectomy, just remove the thyroid gland altogether and solve the problem. Now we're going to go to hypothyroidism. Do you have any questions for hyperthyroidism up to this point? Are you still listening?
No, everything is good, thank you.
Okay, good. When the screen goes black, it's because I'm looking at the chat. Okay, so do you know any causes of hypothyroidism?
Autoimmune disease.
Which one?
Autoimmune.
Autoimmune diseases. Yeah, good. So
it's one that attacks the antibodies of the it produces antibodies that attack the thyroid gland.
Okay, so yeah, okay. That's Hashimoto's thyroiditis, but there's also some other autoimmune thyroid disruptions. So we have chronic autoimmune thyroid disease. So these are the chronic ones. And what you said is one of them. It's Hashimoto. We're going to talk about it later on. But how we can classify it is by using primary, secondary, and tertiary. You will learn this in pathology, so I think in third year. I don't know if you know it already. But primary means it starts from the place of the organ that has this function. So the organ we're talking about is thyroid. So primary hypothyroidism means that it's a problem of the thyroid. So we have the autoimmune diseases, we have some iatrogenic, maybe we did some surgery and removed the thyroid, some trauma, like a car accident that destroyed the thyroid, some radiation that destroyed the thyroid, so another destruction. In poor countries, iodine deficiency, but we don't see it anymore in our countries because we iodinate the food. And then maybe some transient. Transient means that it's going to manifest a bit, but then it's going to go away. So it's transient means it's only temporary. So we are going to talk about them as well. Secondary means that it's the organ that controls that organ. So in this way, in this in this organ, thyroid, the secondary will be pituitary. So pituitary is secreting TSH to the thyroid. So secondary hypothyroidism means that it's one step back from the feedback loop. And tertiary means that it's two steps back from the feedback loop. So in this case, it's TRH, that's the hypothalamus. So these secondary and tertiary, like head trauma, pituitary tumors, and stuff like that, are very rare. So let's not discuss them. So we're going to discuss the primary hyperthyroidism. Do you know which one is the most common from the primary hyperthyroidism? Can you guess? Can you choose? Which one do you think is the most common? A, B, C, D, or E? Just choose one.
D.
You're saying iodine deficiency is the most common. Is that correct? You said iodine deficiency, right?
Yeah, maybe.
It is the most common worldwide because we have a lot of poor countries. So in poor countries, or in general in the world, we have iodine deficiency. That's the most common. But in our countries, like developed countries, the most common is Hashimoto. So you should know that let's say the problem of the developed countries is autoimmunity. You're gonna do it in your hygiene state exam. It's called the hygiene hypothesis. Is that now that we're more clean and stuff like that, our immune system is not so good, so it autoimmunes, it kills itself. So in developed countries, we have autoimmunity. So Hashimoto is the number one. And then for the other countries, the poorer countries that don't have iodinated food, they have iodine deficiency. Okay, good. Now, the diagnosis is the same as hyperthyroidism. You take a history, then you do a physical exam, you take the labs, ultrasound, so, and then finally maybe do some scintigraphy or whatever, so, and antibodies. So the same thing as before. Symptoms, they're almost the same and opposite as hyperthyroidism, but there is some exceptions, okay? So it's not exactly opposite as hypothyroidism. For example, we said the myxedema, that it has both. Myxedema can appear in both. Yeah, so we're going to go through them and see which ones are the exceptions. And the treatment is the levothyroxine, that's the T4, artificial T4. It's going to suppress TSH because you know the feedback loop from physiology, and we're going to use TSH level to dose it. That's in primary hypothyroidism, the most common. If it was central hypothyroidism, that's the tertiary and the secondary and tertiary, then the dosage is based on FT4 because FT4 comes from the thyroid is working normally, the problem is central, so the brain, pituitary, hypothalamus, and our dosage is going to be based on the FT4. While in primary, the disease is the thyroid, the pituitary is working normally, and the hypothalamus, so we use them as a method of control. So that's how you treat hypothyroidism. You use T4, but it depends if it's primary or not, or central, which is your indication for the dosage. It should be taken before breakfast or after dinner. I think here should be like 30 minutes, not 6 hours before breakfast. Yeah, okay. Do you know any artificial T3 drug? And when will we need such a drug? Do we actually need pharmaceutical companies to create an artificial T3? Or is a T4 enough? Just having levothyroxine is enough? Can you just guess if pharmaceutical companies are creating artificial T3?
Doesn't like T4 become T3 eventually? Or is it the opposite way around?
Yes, you're right. T4 becomes T3. So do you think it makes sense for
No. No.
Okay, they are creating it, but it's only for one occasion, only specific indication. We're gonna talk about it in the next one. It's called liothyronine. So liothyronine is the artificial T3, and it has only one indication that I know of. Yeah, let's try to go through the symptoms. So we said dilution anemia. This is hyperthyroidism, and here is hypothyroidism. So we said dilution anemia. Do you think is going to be affected? Like, are they going to have in hypothyroidism a lot of blood now, or are they going to have still anemia? What do you think? Formation of red blood cells. Okay, so basically, formation of red blood cells requires metabolism and energy. So if you're hypothyroidism, your metabolism slows down. So you will have anemia still, but this time it will be anemia due to low production. So low production anemia is called aplastic anemia. What about tremor? Tremor, because of the sympathetic stimulation, what is it going to become for tremor? Don't be shy, you can just open the microphone. So no tremor, hypokinesia, not moving, okay. High heart rate is going to become, in high heart rate in hyperthyroidism becomes, in hypothyroidism, yeah, low heart rate, good. Tachycardia becomes bradycardia. High systolic blood pressure becomes, okay, that's a tricky one. High systolic will become high diastolic, okay? So it will not have low blood pressure. You will still have a bit of high blood pressure, but it will be higher diastolic blood pressure. So that's one of the exceptions. That's why I'm telling you it's not exactly opposite. So anemia, yes, still anemia. It's not exactly opposite. Tremor is exact opposite, becomes hypokinesia. Metabolism, so hypolipidemia becomes hyperlipidemia. But here, okay, I'll give you the answers. Here you have hyponatremia. Okay, so that's the exception one. Oligomenorrhea, which means that your menstruation is happening less often, is going to become amenorrhea, so not at all. So from less often becomes not at all. And in men, it's going to become impotence. So this is the reasons, because in hypothyroidism, you have higher TSH all the time, trying to stimulate the thyroid to come back to normal. But this TSH is also creating prolactin. So TSH is affecting the prolactin, and then the prolactin is important for the reproductive organs. So both of them, hyperthyroidism and hypothyroidism, affect the reproductive organ. That's why your thyroid should be fixed if you want to be fertile. Ophthalmopathy is going to become myxedema. We said the mechanism is fibroblast. If you have low thyroid, then the feedback will say higher TSH, trying to bring the thyroid back, but the thyroid is not listening because it's diseased. So this high TSH is going to go to the fibroblasts and make the myxedema on the receptor of the fibroblasts. Intolerance to heat becomes intolerance to cold and cold skin. Diarrhea becomes constipation. The irritability and sympathetic system and hyperreflexia becomes lethargy and hyporeflexia. Sweating and shortness of breath becomes anhydrosis and again shortness of breath. And then the muscle wasting and weight loss becomes weight gain and macroglossia. So that's myxedema on the tongue. Yeah, so like this. That's the macroglossia. That's the myxedema faces, the face of the myxedema. You see the heart problems, diastolic hypertension, problems with the reproductive system, the muscle problems, the reflexes are prolonged. Yeah, cold intolerance, the hair is dry and brittle. Yeah, so that's the hypothyroidism. These are pictures from Netter, by the way. Yeah. Do you know any life-threatening emergencies of hypothyroidism? So for hyperthyroidism, we said thyroid storm. What about life-threatening emergency of hypothyroidism? Do you know what is it called when you have life-threatening emergency of hypothyroidism? It has to do with the word myxedema. So it's called myxedema. It's two words.
Myxedema coma.
Yeah, myxedema coma. Yeah, good. So before we said that it's the CNS, right? So thyroid storm. If we go back to thyroid storm, we have that it's basically if you have hyperthyroidism with CNS. So CNS is very important and it can lead to coma. So the same way with myxedema coma, it's also CNS with the hypothyroidism. Now it's rare because we have earlier diagnosis and treatment. It's usually an older woman that had a long hypothyroidism and now it's getting decompensated. For example, there is an acute illness like infection or surgery or some other stressor, and then it's becoming decompensated. So similar to thyroid storm, the CNS is very important. So if we see any CNS problem like stupor, lethargy, coma, then we should start to treat it. The thyroid function test, the TSH-T4, can support the diagnosis, but we care, because it's life-threatening emergency, we care first to solve this CNS problem. So the clinical symptoms of the CNS and the history of some stressor is an indication to start stabilization. Put them into the ICU, it's a life-threatening emergency, and try to stabilize them. Look at the history. Do they have a history of risk factor for hypothyroidism? For example, a thyroidectomy scar that would suggest the thyroid is not there. The history of the stress or history of actual hypothyroidism or some procedure that removed the thyroid. Then you look at the hypothermia, which is a sign of hypothyroidism, hyponatremia, another sign, or hypercapnia, that's it means high CO2. Capnia means CO2. That is affecting the muscles of the respiration. And exclude other coma causes. So do the cultures, maybe it's a meningitis or something, metabolic panel, there are arterial blood gases, exclude DMI, take the ECG and stuff. So exclude other coma causes, like try to exclude the other causes. And then we have the symptoms. We said CNS, hypothermia. So we said the stressor could be an infection. So if you have an infection, here you will not have fever. So if you don't see fever in such a patient, don't say, okay, there is no infection. Try to take the cultures. Okay, the cultures never lie, but the fever can lie because this patient is in hypothyroidism. Bradycardia, hypotension, so basically all the things of the hypothyroidism getting exacerbated. Treatment, we said move them to the ICU, put the ventilation on, especially in hypercapnia, try to make them breathe, stabilize them, and then take the bloods. Okay, take the samples before you start the treatment. This way you can have the baseline. Take your cortisol, TSH, T4, the other tests, take everything now. Then you can start the treatment. You can use fluids, vasopressors for the hyponatremia and hypotension. And then this is where the artificial T3 comes in. In mixed edema coma, you should use also T3. It's such a life-threatening emergency that we don't have time to convert T4 to T3. Plus, the conversion is slow. So here we are going to give the artificial T3 as well. Okay, so intravenous T4 and T3, and also give the hydrocortisone, the glucocorticoids. Okay, so the cortisol as well, because they are very, very unwell. If needed, their glucose is very low, give them the glucose, the dextrose solution, give them antibiotics if you find some infection, and then start to rewarm them because they are very, very cold, hypothermia, they cannot do fever themselves, so we start to bring the temperature back. So that's the mixed hematoma. Any questions for hyperthyroid and hypothyroid until now? Any questions on these functional disorders? I'm looking at the chat. Okay, good. So, moving on, we have here goiter and nodules. Do you know what is the difference between goiter and nodules? Okay, I'm going to give you the answer. So, goiter is an enlarged thyroid gland as a whole to more than 2 standard deviations from the mean. So this is how you can define it. But in real action terms, it means that the female have higher than 18 mLs and the males have higher than 22 ml. So the males have a bit higher thyroid size. Nodules means that it's these ones over here. You can see them like this. They are round or oval shaped growths within the thyroid gland. They can be singular or they can be multiple. So this is a nodular goiter. Or they can be diffuse, the goiter. So it means that the whole gland is enlarged uniformly. You can see here the surface that is smooth. Here there's no nodules. Everything is uniformly enlarged compared to the nodules. And you can maybe feel it on palpation. You can see here the different shape. Maybe you can feel it on palpation. Otherwise, use the ultrasound. The ultrasound is a better way to see the nodules. Even if you feel it on palpation, which is not so common in untrained hands, even if you feel it, then you need to use ultrasound. Always use the ultrasound. Okay, you cannot give diagnosis just by palpation. Yeah, and scintigraphy, you can see this is diffuse, for example, that the whole gland is getting affected, and nodules, you can see it's just focal lesions. Here is multi-nodules, a lot of nodules. Yeah, so this is nodules and this is goiter and diffuse goiter and nodular goiter. Okay, so some information. Goiter is common. It's found in a lot of the population, mostly in females, and they are asymptomatic. But the problem is that some of them are malignant. So when they come for the goiter, these are also the presenting complaints. So this is the reason they come to a doctor. It's maybe some cosmetic, like no one wants to walk like this in the neck. So they come from cosmetic reasons. Maybe some thyroid function, like hyperthyroidism or hypothyroidism. We talk about them. Maybe there is some obstruction if they are too big, that they cannot eat, they cannot breathe, and they have a pressure feeling in the neck. Or we need to check basically the malignancy, because there is this 5-10%. So we said most nodules are benign, but we need to find the subtype and mortality and prognosis of this malignancy. How to classify the goiter? You can use it. You can classify it based on function. So you have euthyroid goiter, which means normal, and then hyperthyroid goiter or hypothyroid goiter. So these are classified based on the symptoms and laboratory of the disease. You can classify it based on morphology. We said diffuse and nodular. This is going to help us give direct the diagnosis basically. We can use the ultrasound and try to find which pathology actually it is. And then finally, we can classify them based on their malignant population, so benign and malignant. So this has to do with the prognosis and treatment. Yeah, so moving on, I will help you to have the goiter in your brains, okay, so to remember it. So that's a very quick way to do it, is to use this small table here. So diffuse, you have some simple, which is physiological, like puberty and pregnancy. You have some medically induced, iatrogenic. You have the iodine deficiency, but you will not see it because it's only in poor countries, so you will not see it often in our countries. And then everything else is a kind of thyroiditis. So if you know your thyroiditis, and you can just use it for all the diffuse, you can say, okay, thyroiditis is my diffuse. So if you know your thyroiditis, you are pretty much done with the diffuse. One thyroiditis, which is nodular, is this radial thyroiditis, the fibrotic one. This is the only one that, for me, I consider it diffuse, but it's kind of classified in nodular. So if you do the thyroiditis, then you are pretty much done with most of the diffuse classifications. And then we have two subacute thyroiditis. The one is called, these are all synonyms. So it's the Decorva one, it's the painful one. Subacute granulomatous, or just subacute. Some people, when they say subacute, they directly mean Decorva. Or it can be the other way, the other subacute NTD, which is called subacute lymphocytic. This is the painless one, and it's called silent because it's painless. A special type of this one is called postpartum. Okay, so after you give birth, this type of disease is called postpartum. And why we call it postpartum and not silent is because the postpartum version of this has higher antibodies. And we will talk about it in a few seconds. Now, this is the course of the subacute thyroiditis. They start with hyperthyroid phase. This is because we said there is a destruction of the follicles and the thyroid hormone is getting secreted into the blood that is preformed. So the preformed thyroid hormone is getting secreted into the blood because destruction of the follicles. Then we have a euthyroid phase that it's not secreted so much anymore. Then the gland is destroyed a bit, so it's a hypothyroid phase, and then it comes back to recovery, euthyroidism. So these two subacute ones, they always end up in recovery. That's why they're called subacute or transient. The other ones, if not treated, may continue on to become basically hypothyroidism or hyperthyroidism, depending on the disease. So let's start with the subacute, the first one, the painful Decorvan thyroiditis. Do you know anything about that? Do you know anything about the Decorvan thyroiditis? The painful one? Okay, it's painful. Okay, I'll give you the answer. So basically, it's usually preceded by upper respiratory tract infection. can be some virus or some atypical bacteria. And then after these upper respiratory tract infections, they have thyroid tenderness on palpation and pain. So they go to the otorhinolaryngologist, the ORL, the ENT doctor, complaining of this pain on their throat, on their thyroid basically. And then when you touch there, it's tender. So that's why it's called the painful one. The subacute Dequarvan painful one, diagnosis is clinical. So they come in, you do the inflammation one. So you see that they're actually having inflammation going on. There is no severe symptoms of thyroid dysfunction. What is the problem is that a diffuse goiter, because we said everything that is thyroiditis is diffuse, except renal thyroiditis, the fibrotic one. And then the pain and the tenderness. So pain, tenderness, and diffuse goiter, that's it. With elevations of the inflammatory markers, that's it. You can make the diagnosis. So you can say it's just a painful subacute thyroiditis. The thyroid functional disorders symptoms that we just said before with the myxedema and stuff like that are not present since it has not been enough time for the hypothyroid to manifest. It's just going like hypothyroid, euthyroid, hyperthyroid, euthyroid, and hypothyroid, and then comes back to normal. So you will not see all these symptoms of hypothyroidism in this entity, but the laboratory are changing. So what you can do is follow the T4 and TSH, follow the TSH and T4, follow the laboratory markers and see which phase of the disease are we. And then you expect to find the recovery at a point, and then you can tell them to go away. Since it's the painful one, what you can do is give them non-steroidal anti-inflammatory drugs, so NSAIDs, and prednisone to stop the inflammation. We need to treat the pain because that's the reason they came. They came for the pain, so give them something for the pain and the inflammation. So no need to mess with the thyroid, just focus on the pain. So that's the painful Dequarvan subacute thyroiditis. Then the other subacute is the painless, so this time there is no pain, the silent one. And we said, I already told you that the postpartum is a subcategory that is happening after birth, and this one has higher antibodies than the actual subacute painless one. So what happens here, it's considered a variant of the Hashimoto. Hashimoto is chronic, but this one is subacute. Why is it called a variant? Because it's also with lymphocytes, and there is also 50% of them have the antibodies, but the Dequarvan has no antibodies. So if you have some subacute thyroiditis and you cannot use the pain and tenderness to differentiate, maybe you can use the antibodies, but it's only 50% of the time. And these antibodies will be higher in the postpartum version. We said it already. Diagnosis is clinical in labs. So we have here the hyperthyroidism symptoms, but it's for less than 2 months. So here they do exist, unlike the Dequarvan, which you don't have time to have the symptoms of hyperthyroidism and hypothyroidism. There is no thyroid enlargement or very small diffuse goiter. And we use the labs of the subacute course. So these are the laboratory are the same. You can do the antibodies we said, but they are not as high as Hashimoto, and you should not see any grave symptoms. And the treatment is individual. Okay, so it depends on the patient how you will treat them. Hashimoto is a chronic, we said, and here is the subacute version. So that's why they call it variant. It's not Hashimoto because Hashimoto is chronic. This one is just subacute and transient. And the next one is Riedel's fibrotic invasive thyroiditis. Do you know anything about that? Fibrosis? No. I'm sorry, Kedar, I just saw your message now. Do you know anything about Riedel's fibrotic invasive thyroiditis? I'll just give it to you. So it's a chronic, proliferative, and invasive thyroiditis. So chronic, it comes here in the chronic. Remember that the previous one was subacute. The two previous ones were subacute. The painless and painful are subacute. Then when we go to the Riedel's fibrotic invasive thyroiditis, it's an autoimmune in the chronic spectrum. So it's this one, chronic fibrotic thyroiditis. Okay. So the chronic fibrotic thyroiditis, proliferative because of the lymphocytes and macrophages and eosinophils. Invasive because it goes on the neighboring structures. You can see it here. It's affecting the trachea, esophagus, the muscles, the fascia. It's affecting a lot of things. It's usually in males. We don't know the cause, but it's probably a primary fibrosing disorder because a lot of these patients also have fibrosis in mediastinum and retroperitoneum. So it's not just the thyroid, it's also the retroperitoneum and the mediastinum that is fibrosed. This type of goiter will be stone hard, and it's chronic, so it's not subacute, it's slowly growing, chronic, it's found here. It's going to affect, we said, the adjacent structures, so esophagus, the trachea. Yes, you can find antibodies, but it will be lower than Hashimoto. So if you have really high titers, maybe, and not so hard, then think of Hashimoto, don't think of this fibrosing one. And they can be euthyroid most of the times. The diagnosis is made by biopsy, so do the biopsy and you're going to see the fibrosis. And treatment, this is specialized, is tamoxifen with glucocorticoids. Maybe if it's too much compressing stuff, you can remove it with surgery and then treat any hypothyroid. So that's another entity for thyroiditis, the fibrosing one. And Hashimoto. Okay, finally, Hashimoto. This is the number one cause of goiter in our countries. So goiter, not just the hypothyroidism, but also goiter. Do you know what Hashimoto described? Do you know which disease he actually described? I'm looking at the chat. Anyone knowing what Hashimoto actually described? It's an AI. Autoimmune. Not artificial intelligence, okay. It's an autoimmune disease, okay. Anything else? Okay, I'm giving you the answer. So basically, the natural course of Hashimoto, what he actually described, is a very slow progressing, painless goiter, okay? So it's not a trophic variant from the start, because there is a variant that is atrophic from the beginning. Some books, like Toronto Notes or Up to Date, they have Hashimoto for all of these. They call all of these diseases Hashimoto, but Hashimoto only described the goiterous one, not the atrophic one. So some notes, they say Hashimoto disease can have goiter variant and atrophic variant, but it's not correct to use this approach, especially in pediatrics in first faculty. What we should use is the antibody mediated one. So that's only Graves by itself. The autoimmune with the antibody is only Graves. So that's the hyperthyroidism one. And then we have the autoimmune with the cellular immunity. So split it between antibody or cellular. And then the cellular one has all these entities inside it. One of them is Hashimoto. Don't say that it's Graves and Hashimoto, and then Hashimoto has all of this inside. It's better to say we have antibody and cellular. Antibody is Graves, cellular is all of this. One of them is Hashimoto, which is the goiterous version. The other one, which is atrophic from the beginning without the goiter, it's another variant which is not Hashimoto, okay? So what did Hashimoto describe? He described the goiterous version. So it's very slow progression, painless goiter. It takes months of years of euthyroid. This is the first phase. There is destruction of the thyroid. It's self-limiting, so it's asymptomatic because the rest of the thyroid can compensate. Then we have hypothyroidism. So then rapidly deteriorates into hypothyroidism with the symptoms of hypothyroidism. In between these phases, you may have transient hyperthyroidism. It's called hashitoxicosis. It's when the thyroid hormone in the blood is getting too much high in a very short period of time. But this is limited. It's transient, okay? So the normal progression is asymptomatic and then hypothyroidism. If you have some hashitoxicosis in between, it's just transient. Comes only for like a few days or 1 week and then goes away. Here in Hashimoto, the antibodies do not well correlate with the progression of the disease, so we don't need to do them and monitor them. Unlike Graves, they are in the antibody autoimmunity. So for Graves disease, we need to monitor the antibodies all the time to see how the disease is going. But for the cellular immunity, we just do the antibodies for diagnosis, and then that's it. No need to look at them again. Maybe look at them after 1 year, just to see what's going on. And why is it important to have antibodies in these disorders, to test them, is because we can make the diagnosis in the euthyroid phase. So in the first phase, we can make the diagnosis. So who are we going to check? We're going to check someone who has a family history, who is at risk factors for Hashimoto, has some other autoimmunity like diabetes, and slowly some goiter is growing. So then I will do the antibodies and see if they're too high, and then I will say, look, you have Hashimoto and you are in the first phase. And we expect at the point that you will enter hypothyroidism, we need to monitor it a bit more closely than the normal population. And the moment we see hypothyroidism going on, we're going to start supplementing the thyroid hormones. The cause of the actual Hashimoto disease, we said it's the lymphocytes, chronic, going inside, not so much the antibodies, it's the cellular destruction. They were going to make these ones, the germinal centers. These are high risk for making a lymphoma, okay? We said we have some genetic predisposition with the environmental trigger, and then this will result in antibodies being formed, but the destruction is not mainly antibodies, the destruction is cellular, okay? Infiltration of the cells, they will make this lymphoid nodule, the germinal center, and this is, if it continues to go on, it's a risk for lymphoma, okay? So there is 60 times more than the normal population to have a lymphoma. And how do you know you have a lymphoma? Is when you have a rapidly growing goiter, okay? If it's chronic and slowly growing, it's not a lymphoma, it's the Hashimoto. But if you start suddenly to grow rapidly, then you should think of a lymphoma. And then due to the inflammation, you have fibrosis and atrophy. You see here that is becoming atrophic on the bottom. Epidemiology, so it's the most common cause of hypothyroidism in developed countries, as well as the most common cause of goiter. In developing countries is iodine deficiency. So for Hashimoto in our country, you should know it very well because it's the most common cause of hypothyroidism and goiter. It usually happens in women 30 to 50 years old. In the pediatric population, it happens after 6 years old. This means that it's after third year, so the CNS is okay. Remember in the beginning of the lecture I told you about the pediatrics, that you have some CNS problem. So this happens after 3 years old. So the CNS is okay. What is the problem is the puberty, as we said, thyroid dysfunction of the puberty, and also growth. So know that, yeah, Hashimoto in pediatrics has different effects. Symptoms, we said pediatric, we have the growth as well as the puberty, and the school performance is decreased. They are not super retarded because the CNS is formed okay, but they have school performance decrease. So they cannot function so much. The goiter, so Hashimoto is number one cause of goiter in our countries, is diffuse and non-tender, so it's painless. And we said about the other variants that are atrophic, they are not Hashimoto. Don't call them Hashimoto, call them chronic lymphocytic thyroiditis without goiter or with atrophy. Okay, don't put them into Hashimoto. Our professors don't like that in Czech Republic. And then we said about the two phases, and then we have the symptoms of hypothyroidism. And then let's go into details because we need to know Hashimoto very well. We should go into detail of the symptoms. So in untreated Hashimoto, like you will not every patient of Hashimoto is like this. This is the untreated one, the super severe form. Myxedema, we said how it works. We said about the stimulation of the fibroblasts. So they will have water accumulation plus slower metabolism. This means weight gain and low appetite. So the weight gain is not just fat or the slow metabolism, it's also the water accumulation, okay? So yeah, that's how they get weight gain. So this means that the extremities, if you look at the extremities, they are cold because we said the hypothyroidism people are cold. Anhidrosis, so dry, again from hypothyroidism. And then we have hyperkeratosis and rough mottled elbow. This is here. It's called the Charvat's sign. And this guy, I think, is a Czech, so that's why you should know it for Czech Republic. Charvat's sign is when the elbows are rough and hyperkeratotic and a bit yellowish. This is because carotene cannot convert to vitamin A, so you have hypercarotenemia, so you look like a carrot, so a bit yellowish, your skin. The myxedema location, so we set the face, so this is the facies myxedemica. That's the palpebral, the eyelids, around the eyes, hypomimia, so the muscles cannot work anymore, macroglossia and the larynx, so the voice is affected, the dorsum of the hands, the genitalia, and also the cardiomyopathy, so enlarged heart, poor heart sounds, okay, so the heart is also affected. Yeah, so that's the myxedemas. Going on with the hair, so hair and nails, they are coarse, thin, brittle, and dry. Losing of the lateral 1/3 of the eyebrow. The pituitary can affect, we said, the menstruation due to the prolactin. Metabolism, we said, all of these prolactin, how they affect the metabolism. The hyponatremia, again with hypothyroidism. Hyperlipidemia, again we said these things. The anemia, we said already, the muscles, the GIT, cardiovascular, and the hypothermia. So basically these are the hypothyroidism ones. Diagnosis, Yeah, most important for here is the antibodies. You cannot rely on clinical because we said there is two phases, and the first phase is the normal one, asymptomatic. The labs change before the symptoms, so let's use the TFTs and the antibodies. So do the antibodies. 90% have the anti-TPO to the thyroid peroxidase. Do this first, and this is what is mostly used. And then the second one is anti-thyroglobulin, so anti-TG. We do it if it's negative TPO, or if you're in a rich hospital, you can do both of them at the same time. We said that they don't correlate with the disease, so just do them for diagnosis. Don't follow them up. And then some of them have the blocking type of the anti-TSH receptor, but it's only 10% we said, so we don't care for it. Then do the thyroid function test. That's your TSH, T4, to see which phase you're in, if you're in the euthyroid phase or in the hypothyroid phase. Do the ultrasound to see the goiter, and then don't do the biopsy. You will see the germinal centers on the biopsy and lymphocyte infiltration, but don't do it unless it's a rapidly growing goiter that you suspect thyroid lymphoma. And scintigraphy, again, you don't do it. You can do it if you are confusing Hashimoto with Graves. You can do it. That's the difference on scintigraphy, how you differentiate them. But biopsy and scintigraphy we don't do. It's enough to do antibodies, function test, and ultrasound. And here we have when are the antibodies in hypothyroidism indicated. Asymptomatic goiter, it's what we're trying to make an early diagnosis in the thyroid phase. The thyroiditis, we said, the subclinical thyroiditis, and screening in family history or high-risk individuals, so as a part of screening. Treatment of Hashimoto, it's a treatment of primary hypothyroidism, so we said levothyroxine based on TSH levels, as this is primary hypothyroidism. It's a thyroid problem. If it was central, then we were going to use free T4 for central, but this is peripheral, so use the TSH levels. And if you suspect a lymphoma, do the surgery and remove it. Okay, now we go to Graves. Any questions about Hashimoto? I'm looking at the chat. No question about Hashimoto? Okay, good. So moving for Graves, that's the other autoimmune disease of the thyroid. We said T helper 2 driven, the antibody response, and in this category it's only Graves. So very easy, no cells involved, antibody. It's in the diffuse. We're still in the diffuse with the thyroiditis. So we're still doing it in the diffuse goiter. Epidemiology is the most common cause of hyperthyroidism. The second most common cause of hyperthyroidism is toxic multinodular goiter. From these Graves, not everyone is hyperthyroidism. You have 10% which are euthyroid and 10% which are hypothyroid due to treatment. So you're treating them and they are a Graves patient with the hypothyroidism. So not all of them are hyperthyroidism. Then it's mostly in females. It appears in adolescents as well as 30 to 40-year-old ages. The pathophysiology, we said there is a stimulating type of antibody on the anti-TSH receptor. These antibodies, they stimulate the fibroblasts. We said about the myxedemas, and also the T4 is going to increase sensitivity to catecholamines. Now there is something called the Graves triad, but it's not so common. If you see the triad here, 1, 2, 3, pretibial myxedema or dermopathy, it's only found in 10% of the people. Graves of amopathy is only found to 25 to 50%, but only 3 are severe and need treatment. So we try to change the Graves triad into a different triad. Another specific thing is the activating antibody. So this activating antibody, if you find it, it means Graves. It can mean nothing else. So moving on, we set the symptoms of hyperthyroidism. The first part of the triad is the diffuse goiter, which is a hot nodule, strongly vascular. You can hear this vascularity as a bruit on auscultation of the thyroid, and you can see it using Doppler ultrasound. You can see here the Graves, that is supravascular compared to normal. This is a Doppler ultrasound, and the hyperthyroidism. So that's the third part of the triad. The second part of the triad is the Graves of amopathy. We already spoke about this in the first slide. Let's go on into more detail. So what can we do to these Graves of amopathy? 3% are severe, so how do we know if it's severe and what to do about it? There is a clinical score. There is 2 scores, ATA score and UGOGO score. Then you can use an ultrasound or you can use an MRI, but we rarely use MRI. We just use a clinical score and the ultrasound. So moving on to the clinical score, ATA means American Thyroid Association and UGOGO means European Group on Graves' Orbitopathy. So UGOGO is simple and more used, so we're using this one. Don't use the ATA one, it's a bit too complicated. Maybe if you work in America, you can use it, but you work in Europe, so this is much easier to use. And if you have 3 or more points, it's active orbitopathy. Okay, so that's a clinical scale. And then the ultrasound, so this is the MRI that we don't use. Maybe before surgery you can use MRI, but ultrasound is this one over here. So you can do an ultrasound of the eye and see the muscles and the orbitopathy behind it. Treatment, if you treat it, it's reversible, but you can have some remnants fibrosis there. Of course, you treat the Graves and hyperthyroid, etc. But for the eye, specific for the eye, you should use IV methylprednisolone, high dosages weekly, or a new drug, biological one, IV teprotumumab. Don't use the oral one. You can use it as a second line, but we prefer the intravenous one. Stop smoking, hydrate the eyes. Remember we said that orbitopathy has a complication of ulcerations. So hydrate the eyes with eye drops. This way you avoid the ulcers. And then if it's really severe and it's sight-threatening emergency and the guy is going to go blind, you can use orbital radiation, but this is the negative of this is that it damages the retina, so we avoid it. You can use surgical orbital decompression, so you can go with surgery and decompress the eye, or you can use high dose intravenous methylprednisolone daily for 1 week or a few days. So that's a super high dosage. Then we go to the third one, which is pretibial mixed edema. The name is pretrivial, but actually it's not pretibial, it takes the whole leg. This is, we said, rare, only 10%. It's not just tibia, but also dorsal foot, ankle, maybe upper limb as well. It's the same pathophysiology with the fibroblasts, we said. And how we treat it, again, fix the Graves, hyperthyroidism, avoid the smoking, but this time we don't go IV, we go topical. So use topical glucocorticoid ointment. And again, if it's resistant, use the new drug, teprotumumab, okay? That's the third one. So diagnosis of Graves, we said it's first is clinical hyperthyroidism with a goiter and eye inspection. So you're looking at the Graves triad. The better triad, the new one, is hyperthyroidism with diffuse goiter and new onset of ophthalmopathy. So these 3 things is the new triad. Hyperthyroidism, diffuse goiter, ophthalmopathy, that is new. So use that one, that's a clinical diagnosis. Then go on, do your ultrasound of the thyroid with a Doppler to see the vascularity. Here the bruit, do ultrasound of the eyes if you are to see the extent basically of the orbitopathy. Do your laboratories, find this activating antibody which is specific to Graves. You can do some other antibodies as well, but you can see they're confusing with Hashimoto. Hashimoto has more than the Graves, but focus on activating thyroid receptor antibody. TSH receptor. Okay, so then scintigraphy. You can use scintigraphy to differentiate between these causes of hyperthyroidism. We know that the most common cause of hyperthyroidism is Graves. It will look like this, diffuse. But the second most common is toxic multinodular goiter, which is this one. So scintigraphy can differentiate the most common causes of hyperthyroidism. Now, this is the scheme, the clinical scheme, how to diagnose the different Graves' disease or thyroid problems. So you start with the new triad we said, new onset ophthalmopathy, diffuse goiter, and hyperthyroidism. If this triad exists, then it's a clinical diagnosis. You're done. You have Graves' disease diagnosis. But if you don't have this triad, then you ask yourself, is it nodular or is it diffuse? If it's nodular, then you go to do the scintigraphy, and you can differentiate the Graves, multinodular, and adenoma. So it's what we said here. If it's nodular, you go to make scintigraphy. If it's not nodular and it's diffuse, but without a triad, so triad no, nodular no, so we end up in diffuse without the triad, then go to the antibodies. If it's positive, that's it, Graves' disease, because we said once you have this antibody, only Graves has this antibody. But if you don't have the antibody, then you go to ultrasound, you see this vascularity, then it's Graves' disease. Or you can go through scintigraphy, which we already said how to differentiate on scintigraphy. So yes, we said ultrasound is the vascularity, antibodies, if you find the stimulating, it means Graves, and the clinical triad, if you have it, it means Graves. So that's how you diagnose Graves. And then treatment for Graves, eye specific, we said, the IV corticosteroids. Pretipial myxedema specific, we said, topical corticosteroids. Then the hyperthyroid, we said that we use beta blockers for symptoms, and then the thionamides to stop the synthesis. Now, important here for the Graves' disease is that 1/3 of them, they can make remission. So they have good labs and no symptoms after stopping the medication. So they are treated, kind of. So that's the good thing for Graves. You try the thionamides, you make the dosages, you fix the hypothyroidism, you fix everything, then you stop the treatment, and 1/3 of the patients, they will remain normal. They will have no symptoms and their labs will remain normal. But 2/3 of the Graves patients, after you stop the treatment with the thionamides, they will come back to the hyperthyroidism. So these patients, we call them non-responders. They don't respond to thionamides. So what we can do now is go to a definite treatment. So surgery, remove the thyroid, or radioactive ablation, and then give the levothyroxine. So that's a T4, artificial T4. So remove the thyroid and put our own. Or they can go back to the carbimazole and have lifelong carbimazole. But we said we don't like this option because of the thyroid storm complications. That's why we try to convince them to go to radioactive iodine ablation. So that was the Graves. Any questions for the thyroiditis? So we did the diffuse ones, the subacute ones, all the thyroiditis here. The exception one is radials fibrotic, which is nodular, but I remember it in the diffuse, so I have everything organized in my brain. So if we're done with this part of the table, then we can move on. Do you have any questions? Okay, no. So moving on. Now let's go to the nodular one. We said about the nodules already. So it can be either singular nodule or multi-nodule. So you have a singular nodule or multi-nodule. So here we have the toxic adenoma. It's single and toxic multinodular goiter, many nodules on the thyroid. These are basically nodules or follicles that they were long-standing. They remained there untreated for a long time, and now they gained a mutation, and now they became TSH independent. We call them toxic. Toxic means TSH independent. We don't listen to TSH anymore. We just produce our own thyroid hormone. So a follicular adenoma, which was non-toxic, then mutated and it became toxic adenoma. Or multiple adenomas that were non-toxic, they mutated and they became toxic multinodular goiter. So toxic multinodular goiter is the second most common cause of hyperthyroidism after Graves in the well-iodinated countries. Usually we said it's elderly women because it's long-standing and untreated. And the presenting complaint is the cardiovascular problem. So atrial fibrillation, arrhythmias, dyspnea, heart failure. So they come because of the heart problems. They don't come because of the thyroid problems. This is not Graves, so they don't have ophthalmopathy, don't have the pretibial myxedema, don't have diffuse goiter. It's a nodular goiter. And then our first test will be take the history again, physical exam, ultrasound labs, everything we do with every thyroid. But now it's nodular, right? So we said nodular, do scintigraphy. It's what I showed you before. If you come down the tree, is it nodular? Yes, go to scintigraphy, and then these three you can differentiate on scintigraphy. And here you see the age, that Graves is a bit younger age, and then the older you get, the blue, toxic multinodular goiter, is skyrocketing with age, and it's a number one most common in these ages. And then the solitary toxic adenoma, it's also with age, but is less so than the toxic multinodular goiter, less incidence. And I will emphasize on what I just said. We said the age, so the age plays a role. So here you see patient usually 40 years old or older. You see it's nodular with nodular goiter, it's not diffuse. And then everything else you see here is the cardiovascular. So they came because of heart failure, rapid pulse, tachycardia, atrial fibrillation, heart failure. So they came with the heart problems, and everything else is less than Graves. So less than Graves, no ophthalmopathy, less than Graves, no finger problems, less than Graves. Everything is less than Graves. So basically this is an old woman with long-standing hyperthyroidism that became toxic, and she came because of the heart problems. Okay, so this we said already. Do you have the symptoms of the triad of Graves? No. Is it nodular? Yes. So do the scintigraphy and differentiate them. And that's how you will differentiate them. And the treatment, again, beta blockers because it's hyperthyroidism. We try to gain some time for definitive treatment with thionamides. Be careful because if you give iodides to stop the thyroid storm, you know that giving the iodide is going to make more synthesis because it's toxic goiter. So we have to give the thionamides and then after 1 hour give the iodides in case there is thyroid storm. Why do we say that we have to gain time? It's not a definitive treatment. Unlike Graves, that 1/3 of the patients will be treated with the thionamides, these patients, once you remove the drug, they go back to being hyperthyroid. But this is because they are toxic. They have the mutation. They are TSH independent. They don't care. What they do is just create thyroid hormone. So that's why the thionamides is not a solution. So what is the solution? Is a surgery or radioactive ablation. So remove the thyroid basically because it became toxic. Any questions about the nodules? And then we have only the tumors and then we're done. Any questions about the nodules? Okay, I hope you understand everything. So moving on, there is some cysts in the nodules, they are not tumors, but they are cysts. The cysts are most commonly benign, so we will skip them for this lecture. You can read just the summary of UpToDate or AMBOS just to understand what the cysts are. Just remember that if you see cysts, like clear cysts, the suspicion of malignancy is low. Simple cyst is that it means that everything is cyst. Complex, it means that partially cystic and the partially solid. So this is the one we care about, complex. Complex cysts is 5 to 10% risk from malignancy, okay? So 90 and 95% of the cysts of the complex one will be non-malignant and the simple ones are 100% non-malignant. So yeah, this is the thyroid cysts. So then we should just move on and talk about the neoplasias, the adenomas and carcinomas. So the thyroid neoplasias, they are benign and malignant. We have follicular cells and parafollicular cells, that's the calcitonin ones. This is called medullary carcinoma, 5% of the cases, papillary carcinoma, 80% of the cases, follicular carcinoma, 10% of the cases, anaplastic carcinoma, 2% of the cases. Now the problem here is follicular carcinoma cannot be differentiated from follicular adenoma with the fine needle aspiration. So from the cytology, you cannot differentiate the adenoma from the carcinoma. Why is this important? It's because as internal medicine doctors, if we just want to diagnose the cancer and then send it off to the oncologists and the surgeons. So the surgeons, they care more about the tumor types and stuff because the tumor type is going to tell them which surgery to do and if they need central neck dissection or not, or hemithyroidectomy and stuff like that. So the surgeon will decide how to, together with the oncologist, which surgery to do or which treatment to follow. So as internal medicine doctors, we just need to diagnose them properly and send them off to the oncology and surgeons. So that's why we will not go into so much details of the neoplasms. So as medical doctors, we need to know if there is a malignancy. So there is some red flags and clinical suspicion for the malignancy. So if you see these things, then you should start to suspect malignancy. Okay. Do you know which things we have to look out for malignancy? What is considered red flag for malignancy? Like if you see it, you start considering, okay, this should be a malignancy. We should do something. Can you give me any ideas? Constitutional symptoms, okay, yes, Kedar, good. Other things? I'm looking at the chat. I have here a small exercise. Let's do the small exercise. So, cyst. If it's simple or complex, which one do you think is a red flag for the cyst? Simple or complex? The first one. Which one is a red flag? More suspicious for malignancy. Complex, yes, good. Complex is more suspicious for malignancy. Then TSH, if it's higher normal or if it's low, which one is higher risk for malignancy? So the tumor, do you think it's producing thyroid or not? High, okay. Yes, if TSH is high or normal, it means that the tumor is not producing thyroid, so it's a tumor. Scintigraphy, if it's cold nodule or hot nodule, which nodule do you think is more cancer? Cold or hot? Hot means that it's working, it's secreting thyroid hormone. Cold means that I'm not secreting thyroid hormone anymore. Which one do you think it's a tumor? Hot. No, cold. Cold. I think cold is the tumor. Ultrasound, hyperechoic or isoechoic? Isoechoic means that the thyroid and the nodule have the same color on ultrasound. Hypoechoic means that the nodule on ultrasound is more black. Do you want to do this exercise or just skip to the answer? Can you just write the answers for everything? Big or small, regular, regular? Okay, so I'll give you the answers. So basically, we have different kinds of flags. Ultrasound is the most important, and scintigraphy. Yeah, cold nodules. Cold nodules are the problem. So cold nodules, it means they don't function. So a tumor is not functioning. It's a hypoechoic nodule. You can see here it's black with irregular margins, which means that it's malignancy. It's invading the structures. It's solid, or if it's cystic, then it's a mixed type, the complex one. You got that right. Taller than wide on the transverse section. So we have wide than tall and tall than wide. Don't say oval. It's not just oval. It means taller than wide or wider than taller. So this is taller than wide. It's a malignancy. Microcalcifications extending outside the thyroid. It means that they're invading the patient. History of the patient. Symptoms. We said rapidly enlarging goiter. For example, in Hashimoto, this will mean lymphoma. Some recent onset of compressive symptoms, which they became big too fast. So it's a synonym for rapidly enlarging goiter. So yeah, these are two synonyms. Palpation findings, if it's fixed, it's hard, painless, because painful usually means inflammation. Painless is usually the tumor. Cervical lymphadenopathy, so some metastasis already that is happening. So all of these things, they should make us worry about malignancy. As internal doctors, we don't need to basically do the treatment ourselves. We just need to diagnose it. So this is the first step, the clinical suspicion. Then we found the nodule. What do? We do the history, physical examination, everything we did, palpation, everything like a normal doctor would do anyway on the nodule. WHO has different grading of what does it mean, palpation of thyroid. Grade 0 means no goiter, grade 1 means goiter, and grade 2 means swollen neck, like huge goiter, even with the palpation, even without the palpation. But even if you have grade 0, 1, or even if you have grade 1 or 2, you always have to do ultrasound, okay? Remember, ultrasound always is needed. Do your TSH, ultrasound. Low TSH, it means low risk because the nodule is functioning and the TSH is lower. So the feedback loop is lower because the tumors, they don't make thyroid hormone. The tumors are just tumors. If it's normal or high TSH, it means that the nodule is not functioning, and this is a high risk one. So when should you aspirate and make the biopsy, let's say? When they're too large, when you have the ultrasound suspicion and a bit smaller, and when you have risk factor and too small, okay? So these are like indications, but what you should be using is the ATA guidelines, okay? So ATA guidelines tell you the suspicion, and then they will tell you what is the size that you have to biopsy, what is the limit. So you see here, if it's low suspicion, you need to be a huge tumor. So here, if it's larger, we don't care of any suspicion, just if it's large, just take it. So that's what it says here. We don't care of the suspicion. If it's too large, just take it. And then the more suspicions you have, the smaller the size becomes. So the more suspicious you get, the smaller the size. So we will sample even smaller nodules. And here I highlighted the high risk factors: solid, hypoechoic, partially cystic, irregular margins, taller than wide, microcalcifications, extrathyroidal extension, basically everything we talk in the red flags. So this is the ultrasound criteria. And look at here, purely cystic, no biopsy is needed. So if you have a cyst that is normally like purely cyst, 100% cyst, it's benign. Only if you have partially cyst, the complex one, then you have suspicion. We're gonna go over this in the next slide, I think. Yeah. And then for the low risk ones, so for these pink ones, if you have low TSH, then do the scintigraphy. Okay. Being low risk on the TSH is not enough. We need to do the scintigraphy to find out what is going on with the hypothyroidism. If it's a cold nodule, then we said it's a high risk. So then you go to the criteria again and you use this criteria to take the biopsy. If it's a hot nodule with low TSH, then it's a low risk because we know that cancers don't make thyroid hormone. So then we just treat the hyperthyroidism. And here is the steps. You found the nodule, do your exam, your history, do your TSH, your ultrasound. If the TSH is low, then it's low risk. We have to do scintigraphy. If it's hot nodule, then it's hyperthyroidism. So this is the path we would like to go with the nodules to avoid the cancer. But if the nodule is not working, it's a cancer, TSH is normal or elevated, then we look at the criteria, the ATA criteria. If they are there, or if it's a cold nodule, then we take the biopsy and we look at the cytology. So yeah, that's what we do. And then we have the Bethesda classification. It's basically you did the fine needle aspiration, you see the cytology, and now you do the treatment. We said that the fine needle aspiration cannot differentiate between carcinoma and adenoma. So number 4, which is the follicular cells, they fall in the hemithyroidectomy. Just remove half of the thyroid. We don't know if it's a adenoma or carcinoma. And after you remove it, only then you can do the microscopy, the pathology, the biopsy, the histology, and see if it was cancer or not. For number 1, it's non-diagnostic. There is some criteria. It means that the sample was not enough. Number 2 and number 3, they are benign, so you just watch and wait. And then the number 5 and 6, these are the malignant or suspicious for malignancy. Then you go to the surgeries, okay, or the radiotherapies and stuff like that. So yeah, that's how you do it. For cystic nodule, you can use ethanol or sclerotization therapy for the cysts. Purely cystic, not the complex cysts. So that's a treatment. So that's it. I'm done. So to recap, we started with the functional disorders. We said hyper and hypothyroidism. We said they are emergencies. So that's the first step. Then we went to goiter. So we have all the disease of thyroid inside goiter. If you follow the goiter, you're good to go. You go with the diffuse or nodular. Diffuse, we have all the thyroiditis. If you think that all the thyroiditis is diffuse, and you know this autoimmunity here, and you know also the subacute, then this part of the table is done. You know all these diseases and what they mean. And then when you go to the nodular, just think of the singular and multi, so toxic adenoma, toxic magnodular goiter, and then the cyst. You don't care so much for the cyst because they are benign. So then you're done with the nodules, and then you jump to the tumors, adenomas, carcinomas, and lymphomas, we said for Hashimoto. You go to the tumors, and then what you just need to know is the red flags, when to do the fine needle aspiration, and the Bethesda for what to do when you get the results back. So that's for internal medicine, the thyroid diseases, like how to have them in your brain. That's, I think, the easiest way to do it. Hyper, hypo, and their emergencies. So in generally speaking, the symptoms. Then you move on to this goiter. So if you know hyper, hypo, the goiters, and then just these adenomas, carcinomas, you know all the thyroid. Do you have any questions? Do you have any questions on the lecture? Do you understand thyroid now? Like how to classify thyroid?
better, yes. Thank you.
I hope I didn't confuse you too much. I hope I cleared things in your brain with thyroid. So the way you should study it, I think this is the best way to walk thyroid. Do your hypo, emergencies, then go to your goiters, do your thyroiditis for the diffuse and the subacute, and then move on to the nodules, do your toxics and the cysts, and then finally finish with the tumors. All right, I think we're done for today.
Okay, so thank you so much for the lecture.